Hello guys, welcome back to another video of our respiratory physiology series, and I'll be talking about restrictive and obstructive lung diseases in this video. Now this is a very important topic because it is one of the most frequently asked topic in your exams. And before actually going into this topic, I want you to know that I have already made a video on lung volume and capacities, and that will be very useful for you to understand this topic better. So if you haven't watched those videos yet, I advise you to basically watch those videos first and then come here. I'll just add the video in the above I button so that it will be easier for you to find my videos and watch it as well. So let us start this topic before any delay. So what actually are restrictive lung diseases? In restrictive lung diseases, basically the lung, it restricts from filling. So here we have poor compliance. Now what actually is compliance? Compliance is nothing but stretchability of the lungs. It is the amount the lungs can stretch, the amount the lungs can stretch actually. So here we have poor compliance, the lungs cannot stretch properly, so we have difficulty in inspiration, but the airways are absolutely normal. There is no problem in our airways, they are absolutely normal. And because the lungs are not able to stretch, we have low respiratory movements. On the other hand, in obstructive lung diseases, we have obstruction present. We have narrowed airways, which leads to difficulty in expiration. And here we can find many sounds. We can find wheezing. We can find respiratory sounds over here like wheezing. We can find stridor in obstructive lung diseases. So some examples of obstructive lung diseases are bronchial asthma, we have COPD, we have bronchiectasis, we have bronchiolitis. COPD, we have emphysema and chronic bronchitis. You know that very well. In emphysema, we call the patients as pink puffers. We call the patients as pink puffers, and in chronic bronchiolitis, we call the patients as blue bloaters. I'll talk about these conditions, all these topics separately in my next videos. Here we'll just differentiate these two topics properly, and then I'll go to the particular diseases later on. So what was vital capacity? I'll again explain you what vital capacity is. Vital capacity is nothing but it is maximum inspiration. It is maximum inspiration plus maximum expiration. Just maximum inspiration plus maximum expiration. I told you earlier that this vital capacity, it was different in males and in females. This vital capacity in males, it was 4.8, and in females it was 3.2. The reason it is less in females is that in females we have a low body mass. And I also told you that there are many physiological conditions in which vital capacity is less, which was in females, in short stature, old age, pregnancy, in children, and in supine position. I'll again say you to just watch my previous videos as well, because I have explained everything in details over there, so it will be easier for you to understand. So now vital capacity, it was different in males and females, and we spoke about the physiological causes of low vital capacity. Now what are the pathological causes of low vital capacity basically? So before going to that, I'll talk about TVC. Now what is this TVC? This TVC is nothing but timed vital capacity. So on the basis of time, we have basically divided this TVC again into three parts, which is FEV1, FEV2 and FEV3, which is forced expiratory volume 1, 2 and 3. Now this FEV1, what is this FEV1? It is basically the forced expiratory volume in the first second. It is the part of the VC which came out in the first second. The part of the vital capacity which came out in the first second is called FEV1. So for example, let us take an example. For example, if our TVC is 5 liters and in the first second we have 4 liters, this will be the FEV1, that is in the first second 4 liter of air came out. Okay, so if we get this in a percentage, FEV1 percentage, it will be FEV1 upon TVC into 100. So that will be 4.5 into 100. It will be 80%, or you can say 0.8. So this 0.8 over here, this 0.8, this is actually the normal amount of FEV1 is actually 0.8. We consider normal FEV1 as 0.8. And the another point to be noted, a very important point, is that in obstructive lung diseases FEV1 is always low. That is, the FEV1 in obstructive lung disease like asthma, COPD, etc., the FEV1 will be always less than 0.8. This is a very important point, that FEV1 will always be less in obstructive lung disease. It will be always be less than 0.8. But in restrictive lung disease it will be normal. In restrictive, the FEV1 will be normal. In a similar way, we have FEV2 as well. This FEV2, the normal amount of FEV2 we basically consider is 95% of TVC. And FEV3 is basically 98 to 100%. 98 to 100% of TVC. I hope this was easier for you to understand. And so let us go to another topic as well. So let us go to the other spirometry parameters. In restrictive lung diseases, we have all volume and capacities are low. All the volume and capacities are low, but we have a normal flow rate. I said you earlier also that the flow rate is absolutely normal. The flow rate is absolutely normal here, but all capacities and volume are low. In obstructive lung disease, on the other hand, the volume and capacities, they can be normal, but RV, FRC and TLC are high due to air trapping. Here we have obstruction, because of which the air cannot come out. So we have increased RV, FRC and TLC and a decreased amount of flow rate. And I'll tell you again what actually RV is. RV. What is RV? RV is the amount of air in lungs, the air left in the lungs after a forceful expiration. After a forceful expiration. And what was FRC? FRC was the air left in lungs after a normal respiration, after a normal expiration. After a normal expiration or at rest. I'll again tell you that I have made a video on these lung volume and capacities, and I have explained everything in detail, so it will be easier for you to understand. Just watch the video once. So this is FRC, this is RV, and TLC again is nothing but total lung capacity. So in obstructive lung diseases, all the capacities and volumes, they can be normal, but these three are exceptional, and they are high. They are high due to air trapping, because here we have obstruction, so here the air is trapped. So these three volumes, they are high, and we have a decreased flow rate, and here we have a normal flow rate with all the volume and capacities low. So again I'll go to the type of restrictive lung disease, but before this you should be clear upon one thing. You should be clear with one thing, that if the FEV1 is normal, then the person will be having RLD. You can say the person has RLD if you want to differentiate between those two conditions. And if it will be low, then the person will be having OLD, which is obstructive lung disease. So we can differentiate restrictive and obstructive lung disease on the basis of FEV1 itself. If FEV1 is normal, a person comes to you with any lung pathology and you suggest and you think what sort of lung disease he might be having. So you should check his FEV1 level. If it comes normal, it is a restrictive lung disease, and if it comes less, it is obstructive lung disease. Now the person has low the person has a normal FEV1, but is the person does the person have any pathology, or is the person actually normal? So again, to differentiate between these two conditions, we should check the vital capacity. So you should check the vital capacity of the patient. Now if the vital capacity is normal, then the patient is absolutely normal. The patient doesn't have any respiratory pathology, no lung pathology. He is absolutely normal. But if the vital capacity is low, that means the patient is suffering from a restrictive lung disease. I'll explain it to you again. If a patient comes to you and with any symptoms of a lung disease, then you should differentiate between restrictive and obstructive lung disease first of all, and you should check the FEV1 level. If the FEV1 level is normal, then you can think about restrictive lung disease. If it is less, then you have to go for obstructive lung disease. If the person, now to differentiate if the person is actually having a lung condition or is the patient normal, you should go with vital capacity. If the vital capacity is normal, then the patient is normal with no respiratory pathology. If the vital capacity is low, then the patient has restrictive lung disease. This is a very important thing to know, and I will highlight it, and you can get the notes. You can get the notes which I'm using over here in my video in my Instagram channel. I will just add the details of my Instagram channel in the I button above, and you can get the details about it. So let us continue with the topic. So again, we'll be talking about types of restrictive lung diseases. Here we have intrinsic or parenchymal, extrinsic or extraparenchymal. Now this intrinsic lung disease, here basically what is happening in these intrinsic lung diseases, what the thing is that the lungs are at fault over here. The lungs are at fault. But on the other hand, in extrinsic lung disease, it is not the lungs' fault. It is not the lungs' fault over here. That means the problem in intrinsic lung disease is in our lungs. But in extrinsic lung diseases, the problem is not in the lungs. The problem is somewhere else, maybe in the chest wall, maybe in the neuromuscular system, maybe in the neuronal system, maybe any other disorder which affects the pleura. It can be any other conditions, but the pathology is not in the lungs. The lungs are not involved. But due to these conditions, our lungs are getting compromised. And in intrinsic lung disease, problem is in the lungs. For example, the type of restrictive lung disease, it can be lung fibrosis, which can again be occupational. We can have occupational causes, like we can have silicosis, asbestosis, berylliosis. We can have autoimmune causes like rheumatoid, scleroderma. A drug induced cause like amiodarone causes lung fibrosis, and idiopathic pulmonary fibrosis. The word idiopathic here means that the cause is not known. Cause is not known over here, but still it is considered in this group as well. And in extrinsic, we can have chest wall deformity, we can have kyphoscoliosis, we can have neuromuscular disorders, respiratory muscle paralysis, diaphragm paralysis, we can have disorders affecting the pleura like pleural thickening, we can have pneumothorax, we can have myasthenia gravis, which basically affects the neuromuscular junction. We can have costochondritis. So all these conditions, they can lead to restrictive lung disease. These are extrinsic causes, and these are intrinsic causes. So this is all the basics that you need to know about restrictive and obstructive lung disease, and I'll be talking about all these particular diseases separately in the next videos. You'll be getting to know about these topics as well. So this was all about the basics of restrictive and obstructive lung disease. I hope I made you understand this topic, and just keep on studying. I'll be posting the next videos later on. Thank you so much for watching. Thank you.